So why don't we just go ahead and get started? Why don't you just introduce yourself as people are joining in, uh, who you are, a little bit about yourself.
All right. So my name is Dr. Mark Klion. I am a board certified orthopedic surgeon. I've been in practice in Manhattan for, I don't know, about 24, maybe even 25 years, kind of lost count at this point in time. I've been affiliated with FAMI, I guess now for crazily enough, 15 years, which is an insane number, which I can't believe. I do sports medicine, mostly knees and shoulders, but I take care of pretty much every aspect of the body. I'm an endurance athlete. I've kind of practiced that pretty much my whole life. I still compete. At least I try to, although at 58, it seems like it's getting harder every single day. And that's kind of who I am and what I do. Just happy to be
Okay.
here.
Well, thanks for joining us. As Mark mentioned, Mark and I have known each other for 15 years, and he's been around was since the first year of FAMI, when there were like 15 people in there. And it's obviously grown from that. We're very grateful that he's been a part of the team. It's his contribution has been very valuable. So we're going to cover a wide spectrum of things. And then if you have some questions, feel free to put them in the chat. And one of the things that I wanted to start with is what inspired you to pursue medicine and why surgery?
Well, it's, having a father who's a gastroenterologist is certainly obviously the first draw in all of this. Science was part of my background. That was certainly something that I thrived in. My sister, who's older than myself, is also a physician, more of an infectious disease researcher, but a clinician in her own right. But when I got to medical school and realized that I'm much more of a doer per se, a physical doer, that surgery just seemed like the appropriate direction, for medicine for me. It was very gratifying to go into an operating room and to fix something. So that was my natural passion. And then orthopedics just simply, not necessarily because I was an athlete, but I just enjoyed the aspect of it. And why I fell into sports medicine was that I truly share a passion with whether you're a recreational athlete or you're a highly competitive athlete. I think I have that same mentality. I don't have the genetics to be a highly competitive athlete, but I have a brain, I think, to be that. So I share, simpatico with people that I take care of. So it just seemed like a natural fit, but surgery was certainly much more interesting. And I think my dad, who's brilliant, I couldn't follow his footsteps because I'm not brilliant. So I thought it was a good move to kind of get away from him, actually.
Well, I'm curious, did you ever pursue or did you ever entertain any other type of specialty besides surgery
In the medical field?
Yeah.
Yeah, I mean, I thought ophthalmology was always of interest to me until one day when I walked into the operating room and someone was putting a needle right next to the eye. And I said, that's just not for me. So there were certain things that, someone might say, oh God, orthopedics is so gross. I can't believe you take a hammer and a saw to a bone. To me, that was attractive. To put a needle next to an eye, it really kind of skeeved me out to a certain extent. I really had no desire to do that. So, I think that's.
Had you had any previous experience with using your hands, like woodwork or anything like that at all that you had interest in?
So amazingly so, my dad, who again is a gastroenterologist, is a Mr. Fix-It. So I grew up my whole life, doing that stuff. And he's actually pretty much, even at the age of 88, he's a master craftsman woodworker. And it's funny, me at 58, I'm still his apprentice. So when we go work on something, I go to the bandsaw. He's like, Mark, step to the side. Don't put your hand over there. I said, Dad, I do this every single day with power tools in the operating room. They're equally as dangerous. But the corollary to that is every time we go buy wood at a lumber yard, you go to shake the lumber guy's hand and they're missing fingers. So it's obviously their profession, but, it's a hazard to the profession of losing fingers. So I get it. Yeah, I get it. That's
Who were the two most influential teachers in in your life and that mostly impacted you professionally?
I think most recently, and he's part of FAMI, is Jeff Lateman, and I told that to him, a few months ago, that uh, he was such an inspiration, and he is such an inspiration in terms of his ability to teach, to guide people in the direction that they want to go, to support you. And, when you have people that take interest in you, it really makes a difference in what you want to do in your life. And he was always very supportive. And I really owe him a huge debt to where I am today, because frankly, every conversation that I ever have about orthopedics and every interaction that I have with patients, with residents, with students, is about anatomy. Because if you don't know your anatomy, you absolutely cannot treat a patient. So, to me, that was the biggest impact. Every time I look at a patient, whether it's their knee or their shoulder, it's as if in my mind, I've taken away the skin and I'm looking, at a Netter diagram, or I'm looking at a Jeff Lateman pro section in an anatomy lab, and I visualize that, and it gives me all the keys and the pieces of the puzzle to put together to make a diagnosis. So he really, from a medical standpoint, truly directed me in my career choice.
It's interesting. Carrie, those of you that don't know my wife, she went to Mount Sinai and medical school, and I can't tell you how many people we have met that are now practicing doctors that mention that one of their favorite and greatest learning experiences in medical school was with Dr. Lateman, and to see other lecturers come back, physicians that are in their 60s or even older, that have interacted with Jeff and been inspired as well.
Right.
So that's Jeff. And then who would be the other one?
There were one or two. One I had in college who was a computer professor who it was one class that I really excelled in. And I remember going to the final exam. I didn't have to take the final. He actually begged me to take the final. So I said, okay, fine. I went in, I got every question correct except for the last one. And I said, Mr. Knickerbocker, I cannot figure this out. He said, do me a favor, Mark. He goes, leave your exam here, go get something to eat. Well, let me tell you something. Over the next 6 hours, I repeatedly said to him, when I would come back, clear my brain, try it again, couldn't do it. Finally, at the end, I said, I just can't figure this out. And he goes, that's right, because no one can, because there is no solution to it. And it was kind of like that point of, you got to keep trying, you got to keep trying. And granted, there was no solution to the problem, but the fact that he allowed me the liberty of doing that really just showed me that you have to keep knocking down the door. It's about education. It's about figuring out what your path is and finding your way. And I always went back and said, that was just a great lesson to be learned.
It's interesting. I feel like that is very similar to Dr. Lateman's style of teaching. One of the things that he always stresses in FAMI is to just ask questions. And
Right.
if you see something in anatomy, you don't understand it, then ask why or what.
Right.
So moving on to a little bit more about your endurance career. Yeah. So what was the first endurance competition that you participated in, and also what inspired you to do it?
So I've always been somewhat athletic. I ran track, I pole vaulted in college, but to do an endurance event, I was dared by someone. Actually, he was a cardiologist at Sinai, who dared me to do a triathlon with him. It was 1997. We did the Wyckoff Triathlon, and it was really in the infancy of triathlons at that stage. I had watched the Hawaiian Ironman. It never really kind of sunk into me that that's something that I wanted to do. The minute I caught the bug of that single, triathlon, it was just from there, that's all I really wanted to do. And over the next, 20 years, I've done 11 Ironman, and then I've now progressed to other, endurance events. And, the pinnacle soon to be, it was supposed to be the spring, but unfortunately, because of COVID, was running the Zion 100, ultra marathon. So we're working our way towards that 100-miler. That's the next thing.
So when you say you caught that bug, can you describe that a little bit more? Because, one of the things that I wanted to touch on a little bit is this mentality of the endurance athlete, because they often come across our paths. And it is because the endurance sports is such a mental game. There can be challenges with them, not some more of negotiating that endurance mentality.
Right. I mean, I think that, first of all, from a triathlon standpoint, I think the attraction was that there were 3 different events. One, I'm not a great swimmer. I'm an okay swimmer. I never really loved swimming. 2, cycling for me was bringing me back to a kid, riding a bike around town and just having that freedom. 3, running was, again, a great activity. I think that's my strongest activity, but it was the fact that you didn't have to keep, droning the same activity and you were working different body parts. And I felt that was always very good. I live by the motto, my favorite band is U2, the song, I still haven't found what I'm looking for. That's clearly kind of my life. But I think that's not that I'm not going to find it, but actually an 8th grade teacher of mine who was a Taoist, tells a story about falling into nirvana. And I truly believe that there's going to be a race, and there have been 1 or 2 in my life where I have laid everything on the line. I have opened up my soul to things where, I won't belabor the point, but we did the Grand Canyon, we called it Rim to Rim to Rim. And all I wanted on the way back, so that's 48 miles in the Grand Canyon, Phantom Ranch, which is at the bottom of the Colorado River, all I really wanted was a Coke from that snack bar. That was focused in my mind. And it was 4:30 and the snack bar or the ranch itself closed at 4. There I was, if anybody remembers The Graduate, the movie with Dustin Hoffman, I was standing at the window with a $20 bill banging on the window, asking the guy for a Coke. And if you weren't a member of the Phantom Ranch, you were as good as being a porcupine, going through the garbage. There was nothing for you. And I mentally broke, literally like down on the ground, crying like a baby because that was it. But to tell you the truth, long story short, I got myself back up. I walked out of the canyon. I found my Coca-Cola, my bag of chips, and I was fine. And I operated the next day. And it's those experiences that, if you read the books, you read David Goggins, you read any one of these people, there's something in all of our brains to a certain extent that want to push, whether it's athletics, whether it's anything, you want to push yourself to the limit to see what you can and what you can't do. So for me, and for what I see in endurance athletes, they just want to keep pushing the envelope. It's all up here that stop you. Yes, your body breaks down here and there, and you have to learn how to kind of navigate those little hurdles, but it's really your brain that's stopping you from doing that stuff. So to me, that's the biggest challenge of everything, is just getting your brain to not say no, but getting your body to keep going and not have issues.
What was your most recent competition that you participated
Well, everything was canceled.
Yeah.
But this weekend we actually we were up in the White Mountains and we did what's called the Presidential Traverse, which is about a 20-mile hike / run over 7 of the multiple peaks, which includes Mount Washington. So, we started at almost 5 in the morning and finished about 5, at night. So it's about a 12-hour, 20-mile, 9,000 foot, or so, whatever hike. But yeah, I mean, we've prepared for a bunch of things this year, and, we're just trying to plug in anything that we certainly can do, amongst COVID. So it's been difficult this year.
Yeah, I follow you on social media, and you did that one race where you were on the treadmill, then you were out running around your house. Why don't you tell everybody a little bit about that?
So there's a race called the Backyard Ultra. Essentially, the concept is that every hour on the hour, you're required to run 4.167 miles. The whole idea is it ultimately is the last man standing, the last person standing. So if you can run that 4.167 miles in 30 minutes, you have 30 minutes to rest. But at that bell, at an hour, you need to run again that 4.167 miles. Why that distance? Well, after 24 hours, that equals 100 miles. So the world's record happens to be in the 268-mile range. So what happened this year, it's normally done outside, but because of COVID, they turned it into a virtual race. So you were anywhere that you wanted to be. You had to be by yourself. So I did it at home. So I ran 30 plus miles on a treadmill. I decided to go outside for a few, ran 50 miles in that 12-hour span. And then decided, with COVID around, I didn't really want to run much more. I certainly could have run much more, but the guys that won this, were in the 260-mile range. So they went from 9 in the morning till 11 o'clock on Monday evening. And the two finalists, one was from Virginia and one was from Czechoslovakia. And they disqualified the person from Czechoslovakia because there was an electronic issue with his iPad. And when the bell goes off, if you don't leave or start your treadmill, you get disqualified. And they disqualified him. And it was really like an emotional event. I got to tell you something. There were over 1,000 people online watching this. And when the events happened, the guy who was the race director started crying. He felt so terrible, but that was the rules of the race. But it's an interesting format, last man standing.
So you've touched on a couple of things that I was going to ask you about, the mentality of an endurance athlete. And I would venture to say, because I'm sure your network, there are a lot of other endurance athletes during COVID, because right now what's happening with the fitness industry is we're slowly but surely starting to see clients again. Mentally, where are a lot of these endurance athletes because they are not able to compete? Do you think some of them are dealing with some sort of depression? What do you think is happening in general with them?
Yeah, I think people are still out running. The group of people that I run with, we're still out running. We wear masks, we try to socially distance. We're kind of our own little running pod. So if you think that that's safe and you take the calculated risk, we've certainly lessened a little bit, but I think it has been very difficult because, our lives are arranged around racing and the training for it. And now suddenly you take that racing component out. And even though they've put up these virtual races, they're the same, but it's not the same, mano a mano competition. That backyard ultra is intended to keep everybody together, because it's really, the last person standing. So you get down to 2 or 3 people, and you get to that finish line, who's going to really step up to the plate and do it? So, and there's a lot of camaraderie because you're trying to go as long as possible. And even in these ultra marathons, which I'm not winning these things, but you meet people along the way, and it's the discussions that you have over a 20-hour period with people and meeting people, the social aspect. I think it's been very difficult. I think you're right. I think there are some issues with depression. And it's made it difficult for endurance athletes.
Yeah. It was interesting. I was speaking to another marathon runner it was another orthopedic surgeon. And he said, one of the things that people are speculating though, is once COVID is whenever we get back to a live race, people will be breaking records because these athletes that are typically overtraining and running with injuries will probably be at their peak in terms of health and recovering from injuries.
Yeah, I think that's a great point. Certainly even myself, I've had a little bit of a foot issue, which popped up kind of in our big, lead up to some of the stuff that we did over the summer. And I finally just said, you know what? I have no races on the docket. The next major event is April of next year. I'm going to stop running for 3 weeks, and I stopped running. I've been biking and lifting and things like that, but my foot pain just went away. And I think if you can break it down and accept that you don't have a race till 6 months from now, this is the perfect time to allow the body to heal. I'm not sure that people will be breaking lots of records, but I think people will be in a better state. And it is the optimum time. I had hernia surgery, at the beginning of the summer, because that was really the one thing that was not necessarily stopping me from running, but I was having pain from it. And I said, I have no races. This is like the perfect time to have my hernia taken care of. I had it done. Now I'm totally fine. So this is a good time to recover, to gain strength again, and put that into the mix and see how that works.
So one of the things that happens a lot with us is and I say us, just general fitness professionals, but when we get these endurance athletes, they want us to push them. They want an intense session. And one of the things that, it's not just Pilates, but I think one of the fortes of Pilates is corrective exercise and really focusing on poor biomechanics. And what is your suggestion to any of us out there that have run up against that mentality of just communicating with this person that, yes, we can get there, but you may need to take a step back and move a different way for a while?
Yeah, I mean, I think with experience from an endurance athlete standpoint, that's where, or maturity, that's where you start to understand things. But it's certainly, the younger patient that may not have an experience living through an injury. I think you definitely have to, as I tell everybody, besides sleep, which is probably the most important aspect of recovery, it is taking these, moments and times, these sessions with, Pilates instructors, with yoga instructors, to work on biomechanics. Because once there is an inherent weakness, biomechanics get thrown off, and then you're just spiraling down to having an overuse type injury. I mean, that's, endurance athletes, it's not, you can fall off your bike, you can fall, you can break your wrist. But when you're talking about patellofemoral problems, a swimmer, when you're talking about shoulder impingement, it's all about technique, and it's all about biomechanics. And you have to just break it down, and you have to be positive with the fact that these workouts will make you better, will make you stronger. So the emphasis is on, it's about injury prevention, it's about strength, it's about biomechanics, and ultimately that's going to keep you racing. So I just think it's about perspective, and any athlete out there that's not taking some time off, doing a recovery period, which could be, a Pilates workout, they're really missing the boat.
Well, I think you just actually hit on a very valuable point, and that is this type of training that we could give them the goal is to ultimately keep them racing. It's not to stop them. Right. And we are a part of their support network.
Right.
So let's just, since we are going to cover for FAMI 2, we're going to cover shoulder. I wanted to just ask you a couple of questions about that. So what is the most difficult thing in terms of dealing with the shoulder and shoulder injuries, in terms of surgeries? What's the most difficult surgery that you perform? And, also the potentially most challenging injury for a patient to recover from?
Right. I'll put it into the 30,000-foot view. It's patient expectation. So you can have a shoulder dislocation, which, we can deal with reliably and decrease, redislocation, especially in a young person. You can have a fracture, and, you'll know that will heal given some time. Rotator cuff injuries are probably one of the harder things to deal with, just because it's limited by the inherent nature of the tissue that we're dealing with. But first and foremost, it's really patient expectation. So having the patient understand that although we're good, we're not perfect. We are not evolution. We're not the person upstairs. We've got great technology. But I think rotator cuff surgery can be probably not necessarily from a technical standpoint, but from a recovery standpoint, because you and I even were kind of at the upper age a little bit of the traumatic, young, healthy rotator cuff. I like to think that my rotator cuff is pretty healthy. But when you have a 20-year-old or 30-year-old who tears their rotator cuff, which is rare, traumatically, it's a tendon that's getting pulled out of the bone. Good tendon, good bone. Sew it back together, you get a great result. But as you start to ascend the decades of life and you get to the 50s, 60s, and now to the 70s, a lot of those tears are degenerative, meaning that, again, think about the rotator cuff as a telephone cable. You're pulling hard, you're pulling long on it. Of the gazillion wires that are in it, some start to rip out. Body tries to heal it, doesn't do a great job. And now instead of, let's say, being a centimeter thick, it's a third of a centimeter. It's 3 millimeters thick. And when you go to sew that 3 millimeters back to bone, not the greatest tissue, not the greatest blood supply. And now you got someone who might have diabetes, and that healing potential throws a little bit of a curveball. So I think that from a surgical standpoint, for the most part, we can repair those, but it's the rehab afterwards. It's the guidance, with standard physical therapy. And then with ultimately, because there's always a gap, insurance stops you at 12 weeks, whatever it does. And then you're kind of left in this void of, where do I go to next? And that's where, frankly, Pilates is that great transition, because it's really functional exercise. It's really, safe exercises, where patients really do get that kind of return to normalcy. But when you look at a rotator cuff, you're looking at 6 months of rehab, at a minimum. And that's a lot of work. So I tell patients, and no different when I do an ACL reconstruction. I say, look, I can fix your rotator cuff fairly reliably. I can fix your ACL, I can reconstruct it, but you are the one that has to make this work. I'm happy to walk down the path with you, and I'll see you every week if I need to, but I can't do your exercises for you, And I think that's the difficult part about it, is that it's so labor intensive of rehab and commitment by the patient that really dictates, the prognosis and how they ultimately do.
It's so interesting, because I think you've hit on something that resonates with us. We're all in this healthcare continuum together. And, a client comes to us 1 time a week, 2 times a week, but still at the end of the day, that's only 2 times a week. And to your point, rotator cuff recovery is significant, and there has to be a dedication. And one of the valuable things that I think you've stressed is basically having a very candid conversation with the patient client, and just talking about essentially client-patient accountability. Yep. And that they have to be consistent, and we can't do it all. We can give them the information, we can support them, but at the end of the day, we're a team.
Completely.
So just switching a little more specific with an anatomy question. So is there anything about the shoulder and knee comparatively, working with the two of them, that either interests you more one way or the other?
I think they have their own inherent biomechanical issues. I think the shoulder is pretty unique in that, I always equate it, and I draw pictures for all of my patients. It's like a golf ball sitting on a tee. And that golf ball can roll off that tee, which would be an instability episode. It can roll on that tee, which is standard motion. And it's really held into place by both a dynamic system, which is a group of muscles, but also a static system, a set of ligaments. But the interesting thing about the shoulder is it's really only bound to our body through the clavicle. That's the only bony attachment that the shoulder makes. It's all muscles. So when you look at all the cogs in the wheel, of the rhomboids, the levator scapula, the trapezius, all the rotator cuff tendons, one of those little cogs is not correct. The shoulder goes into dysfunction, and that's what creates pain. And for me, it's a little bit easier in the knee. It's your meniscus, it's your articular cartilage, or it's a ligament. But the shoulder, there's just so much involved with it that you kind of have to figure out, what's really causing the problem. And we break it down to basics, but the shoulder is an interesting joint, and it's a pretty complex joint. Look, I like both of them. Don't get me wrong.
Yeah. Well, I think it's, I think the thing that's interesting about the shoulder is it is so complex there are so many subtleties that can be happening biomechanically that, in just looking at it at face value, not a major thing. And maybe the patient or client doesn't even really sense it. But over a 5-year period, that could really turn into something significant. We had our piano tuned the other day by a guy, and he uses the same arm, right, same shoulder. He's in an awkward position, and ended up having rotator cuff issues.
Right.
So I just wanted to open up if anybody had any questions for Dr. Klion. You can turn on your video if you want and just ask the question. Anybody?
Sure.
Yeah.
So I'm about midway through the equipment training, so I'm not finished yet. I'm kind of wondering about shoulder impingement. I guess really anything that you could offer about it, like how to address it, or what are the root causes of it. Yeah, like the shoulder, as you're saying, is so complex and confusing. I'm just like kind of trying to find an inroad to like start looking at it.
I mean, I think that if you have someone who has a full range of motion and what you would consider to be normal strength, there has to be some muscular imbalance. I mean, that would be the first aspect of this, in which, something's not firing at the right time. I always evaluate a patient either in a gown or without a shirt on, looking from the back. The great thing is that you can use the opposite extremity to evaluate symmetry. Mother Nature is very symmetric. Yes, some people are dominant more so on one side than the other. But when there's scapular dyskinesia, I mean, that's a root cause of most classic shoulder impingement. So if you see the scapula not moving correctly, you have to address the posterior stabilizers, of the shoulder. As you dig deeper, then it starts to be rotator cuff. And that really needs to be diagnosed by, some type of imaging technique, especially if it's been chronic in nature. But, again, visual examination of someone in terms of symmetry, I think is the basics for what you really need to do. And that's the first starting place.
I'm curious, how much of an impact do you think, or do you see on a regular basis, that poor posture can really impact the shoulder and the biomechanics? And I mean, not being subtle about it, significant kyphosis, forward head, how much does that contribute to poor biomechanics?
Well, I have my son who's 15 years old who's got a subluxating shoulder. And if you look at his posture, it's terrible. And I think that's clearly, part of it. Clearly part of it is the, posterior stabilizers. But there's no question that posture is a big component, that leads you down this rabbit hole. So that's certainly something to address. It's hard, to teach old dogs new tricks. It's hard to change someone's, structural kyphosis, if they really do have some spinal issues. But if it's really, correctable and you can get them to be back, then you've got to work on that. But it's clearly a component of it.
Right. So obviously the neck is a big, forward head can be a big contributor to that. Because obviously one of the things where Pilates instructors and other movement instructors can be very effective is addressing poor posture.
Right. I mean, again, there's always such an interplay between the neck and the shoulder. So whenever someone says, I have shoulder pain, the first place I'm looking, is up in the neck. And when they have neck pain, I'm looking at their shoulder. They're just intertwined so much that you can easily miss something, if you're really not looking for it.
Okay. Anybody else have any other questions? All righty. Thanks, Dr. Klion. Mark. Again, he will be lecturing at FAMI 2. If you've been to FAMI, you can come and attend that. We're going to be covering the shoulder. And so right now, you don't have any races scheduled that you're going to be a part of?
No? Unfortunately, no.
All right. All righty. Well, thanks again for your time, and thanks everybody for joining us.
Take care.
Take care.
Bye-bye.